Choosing an antibiotic is usually a pretty straightforward medical decision, but when your patient is pregnant, that routine choice suddenly becomes one of the most critical balancing acts in all of medicine. Welcome to The Explainer. Today, we are diving deep into that high-stakes world where pharmacology, infectious disease, and obstetrics all intersect. A place where every single choice impacts not one life, but two. Okay, so let's get right to the core of it. The central challenge, really the entire dilemma of this topic, is this constant, delicate balance. On one hand, you have the very real, very serious dangers that an untreated infection poses to the mother and to the pregnancy itself. But on the other hand, you've got the potential for medication to be toxic to the developing fetus. Every single clinical decision is about weighing these two competing risks. So to really get a handle on this, we're going to build our understanding from the ground up. We'll start with the foundational principles of antimicrobial stewardship, then we'll apply those to some common urogenital infections. From there, we'll look at critical prevention strategies like GBS prophylaxis and tackle some high-risk systemic infections. And finally, we'll put it all together and test our knowledge with a couple of real-world case lectures. All right, let's begin with the ground rules. Think of these as the fundamental principles of antimicrobial stewardship that have to guide every single prescription for this very unique patient population. Effective stewardship here really boils down to three key ideas. Now, the first two are pretty universal. You've got to use local resistance data, your antibiogram, to pick a drug that's actually going to work. And of course, you want to use the narrowest spectrum agent you can to minimize collateral damage and resistance. But the third one? This one's a fascinating quirk of early pregnancy. The risk of birth defects, what we call teratogenicity, is actually quite low before the embryo implants. Why? Well, it's because of something called the all-or-nothing effect. At this very early stage, a toxic exposure typically either prevents implantation from happening at all, or if it does implant, it has no lasting effect. This quote, it really just hits the nail on the head, doesn't it? It's such a simple but powerful warning. Overprescription isn't just a bad habit, it's a direct pathway to creating drug-resistant pathogens. And that complicates care not just for your one patient, but for everyone down the line. Okay, so with those principles locked in, let's start applying them. We'll kick things off with some of the most common scenarios that clinicians are going to face. Urogenital infections during pregnancy. First up is chlamydia trachomatis. If this is left untreated, the risks are pretty significant. We're talking preterm birth and then transmission to the baby during delivery, which can lead to nasty things like pneumonia and conjunctivitis. So the clinical takeaway here is very, very simple. Treatment is absolutely paramount. It's non-negotiable. Now, when it comes to treating chlamydia, the pathway is all about prioritizing fetal safety. Our first-line therapy is a single 1-gram dose of azithromycin. It's effective and safe throughout the entire pregnancy. Amoxicillin is a very solid second choice. But look at doxycycline. It is strictly off-limits in the second and third trimesters, and the reason is critical. As a tetracycline antibiotic, it binds to calcium, and it can get deposited in the fetus's developing bones and teeth, causing permanent discoloration and potentially affecting bone growth. Now, for something like a simple bladder infection and uncomplicated cystitis, we face another key decision. Nitrofurantone is the first-line choice. It works well, but its use is restricted right at the very end of pregnancy, near term, because of a small risk of causing jaundice in the newborn. And this is what makes coamoxiclav such a valuable second-line agent, especially since it often has a better side effect profile for the mother throughout the pregnancy. But what happens when that simple UTI goes systemic? The patient has a fever or flank pain, signs of a much more serious infection like pyelonephritis. This is a completely different ballgame. Management here means hospitalization for intravenous antibiotics. The go-to first-line agent is a third-generation cephalosporin like ceftriaxone, and you're looking at a much longer treatment course, usually about 10 to 14 days. So beyond just treating active infections, a huge part of good stewardship is prevention. And there is nowhere this is more critical than with Group B streptococcus, or GBS. This bacterium is a leading cause of life-threatening sepsis in newborn babies. The strategy to protect the newborn is something we call intrapartum antibiotic prophylaxis, basically giving IV antibiotics to the mother during labor. Now, it's specifically indicated for high-risk situations, like if a mother had a previous baby with GBS disease, or if we find GBS in her urine during the current pregnancy. But here's the key to making it work: timing. To get those antibiotics across the placenta and to protective levels in the fetus, that first dose has to be given at least 4 hours before delivery. That 4-hour window is absolutely critical. All right, let's escalate a bit and talk about some of the most high-risk systemic infections. Now, these are less common, thankfully, but when they do happen, the consequences can be absolutely devastating for both the mother and the fetus. 83%. Just let that number sink in. 83% of maternal listeria infections lead to a severe outcome. We're talking miscarriage, stillbirth, or a critically ill newborn. This one statistic just powerfully underscores the profound danger of this foodborne pathogen during pregnancy, and it's why vigilant food safety counseling is maybe the most important intervention we have. And if you look at when the listeria infection happens, the picture gets even more stark. An infection in early pregnancy carries a staggering 65% risk of fetal or neonatal death. Now, while that risk does drop later in pregnancy, it's still a massive 26%. The message couldn't be clearer. Listeria is a profound threat throughout the entire gestation. And the risks don't just stop at delivery. In the postpartum period, we worry about puerperal fever, often caused by group A streptococcus. An invasive infection, which is confirmed by isolating S. pyogenes from a sterile site like the blood, is considered a public health emergency. This isn't just something to note in the chart. It requires mandatory reporting to public health authorities. So, how do you treat the most severe form of this, postpartum toxic shock syndrome? You need an aggressive, two-pronged attack. You hit it with benzyl penicillin to kill the bacteria itself. But the real danger here comes from the toxins the bacteria produce. That's why you add clindamycin. It works at the ribosomal level to literally shut down the bacteria's toxin-making factory. This combination is absolutely critical, and it's given for a full 2 weeks. Okay, we have covered a lot of theory and principles. Let's put it all into practice now. In this final section, we're going to walk through a couple of case lectures just to solidify these concepts and see how they actually play out in a real-world clinical setting. All right, here we go. Case number 1. You have a patient, she's in her 3rd trimester, and she's just been diagnosed with chlamydia. So based on everything we've talked about, what's the appropriate first-line agent? And maybe more importantly, what's the specific reason you absolutely have to avoid doxycycline? If you said a single 1-gram oral dose of azithromycin, you are spot on. That's the first choice. And doxycycline is the one to avoid because, as a tetracycline, it chelates calcium and gets incorporated into developing fetal bone and teeth. This can cause permanent tooth standing and potentially interfere with osteogenesis or bone formation. It is a perfect real-world example of prioritizing fetal safety. Okay, let's shift to a neonatal case. We have a newborn who's showing signs of infection shortly after birth, but we don't know the pathogen yet. The cultures are still pending. What's the standard empiric antibiotic therapy you're going to start with? And what are the specific criteria that will allow you to safely stop that treatment? The standard empiric therapy, the go-to combo, is IV benzylpenicillin plus an aminoglycoside, like gentamicin. This covers your most likely culprits, benzylpenicillin for group B strep and the aminoglycoside for gram-negatives like E. coli. But good stewardship also means knowing when to de-escalate. So if after 36 to 48 hours the blood cultures come back negative and the infection markers are low and stable, it is critical to stop the antibiotics. You want to prevent that unnecessary exposure and avoid driving resistance. And that brings us to our final forward-looking question. We've reviewed the best practices for today, but pathogens are constantly evolving and antimicrobial resistance is a relentless, growing threat. The challenge that lies ahead for all of us is this: how must our strategies adapt to continue protecting the next generation of mothers and newborns? Thank you for joining this explainer.